Hi, my name is Kasey Petika, and in the fall I'll be a junior at Triway High School. This summer I had the opportunity to work at the Worcester Family Health Center in the Science Internship Program. The title of my presentation is Physician-Derived Variations in Procedural Sedation During Endoscopy. Here's an outline of my presentation. I will be hitting the major points like background, the study, findings, and results. Background. An endoscopy is when the physician inserts a flexible scope into the esophagus or the rectum. When they enter through the esophagus, it is called an esophageal-gastroendoscopy. During this procedure, the physician examines the upper part of the gastrointestinal tract. This includes the esophagus, stomach, and the duodenum. They are looking for redness, irritation, bleeding, ulcers, and tumors. When they enter through the rectum, it's called the colonoscopy. During this procedure, the physician examines the lower part of the gastrointestinal tract. This is done to screen for colon cancer and the other possible problems related to the lower gastrointestinal tract. During an endoscopic procedure, the patient is given medicine, which puts them into a state of conscious sedation. There are many different levels of sedation. A few are analgesia, relief of pain; minimal sedation, responds normally; moderate sedation, responds with commands; deep sedation, not able to be easily aroused; general anesthesia, cannot be aroused; and dissociative sedation, a trance-like state. To maintain this level of consciousness, sedation medicines called meperidine and midazolam are used, or better known as Demerol and Versed. Demerol is used in the management of moderate to severe pain, while Versed is used for moderate sedation during the procedure. During an endoscopic procedure, the nurse records how comfortable the patient is by marking their level of consciousness. This is scored on a modified Ramsey score. It is on a scale of 1 to 6. The different numbers represent the different levels. 1. Anxious. 2. Awake and tranquil. 3. Drowsy but can respond. 4. Asleep but respond to loud auditory stimulus. 5. Asleep with minimal response. 6. Asleep with no response. The study. My hypothesis was the initial amount of medication given and the manner it is given affects the level of conscious sedation at the start of the procedure and the need to give more medication. The methodology for this study was a blind retrospective chart review. The study was chosen based on the date of procedure from December 1st, 2010 until June 8th, 2011. This gave me 654 patients. They were excluded if their charts did not have adequate information, if they had a procedure other than an upper or lower scope, such as a sigmoid scope, or if sedatives other than Versed and Demerol were used. I collected all the data I needed from the patient's history and physical, as well as their endoscopic reports. This data includes the physician, normal Versed dose based on physician, as well as the normal Demerol, amount of Versed needed, amount of Demerol needed for the procedure, the type of procedure, level of consciousness at the start of the procedure, amount of Versed given to proceed with the procedure, amount of Demerol given to proceed with the procedure, level of consciousness at the addition of more medicine, and the level of pain at the addition of more medicine. Findings of my study. This graph shows the starting dose. The green is demonstrated for the average Demerol, while the purple is the average Versed. I added an extra axis to represent the average level of consciousness at the beginning of the procedure. You can see that the amount of medicine given is varied throughout the physicians, but the level of consciousness seems to stay even. This graph represents the additional medicine given. Once again, the green is the Demerol, while the purple represents Versed dose. The extra axis also represents the level of consciousness. Here you can see that doctors 2 through 5 are evening out the amount of medication given, while doctor number 1 is giving a large amount extra Demerol than the others, but their level of consciousness at the addition seems to stay the same. Additional medication can be given for many reasons. A few may be that the patient is experiencing pain. This pain may be due to cramping, bloating, or stretching. Or it could be given because the patient is agitated. This would be the patient pulling at the scope or being aggressive. This chart represents the percentage of time extra medicine was given. You can see this time that doctors 1 through 5 are giving the amount of extra medication a different percentage of time. There's not a common trend. Let's now take a more specific look at the different doctors. Here we have Dr. 1, where it shows that his starting Demerol dose averages at a 98.63 with a starting Versed of 2.85. At the need of additional medicine, you can see he gives a 58.93 Demerol and a 1.66 Versed. Dr. 2 gives an average starting Demerol of 87.76 and a 4.83 average Versed dose. In addition, 27.6 Demerol and 2.72 Versed are given. Dr. 3, on the other hand, gives an average dose of 91.03 Demerol with a 3.37 Versed. The additional amount of Demerol given is a 26.11 and a 0.93 Versed. Dr. 4 gives a 64.46 Demerol dose with a 3.53 Versed dose. The additional Demerol is a 28.18 and a 1.08 Versed dose. Dr. 5 gives a starting Demerol dose of 50 and a starting Versed dose of 2.88. The additional Demerol is a 25 and the additional Versed a 2. Results. From this study, it was found that the starting dose of Demerol ranges from 50 to 98.63, with an average dose being 78.38. And the starting dose for Versed ranges from 2.85 to 4.83, with an average dose of 3.49. It is also found that the doctors were starting the procedure at around the same level of consciousness, in between a 2 and a 3 on the modified Ramsey scale. So, the patient is tranquil but drowsy on average at the start of the procedure. For the additional medication, it was found that Demerol additions range from 25 to 58.93, with an average dose of 33.16. Versed additions range from 0.97 to 2.27, with an average dose of 1.68. Discussions. It is important to continue to monitor the quality of sedation patients receive during interventions and to be aware of different options available for more comfort. Physician interaction with the patient may affect the patient comfort. Observations. The 5 of the doctors have different ways they interact with the patient. Is it possible that the way they talk with the patient, being quiet and talking with the patient at the bedside, like Dr. 4, is better than being loud and not talking with the patient, like Dr. Number 1? Also, it could be found that the patient characteristics or type of procedure play a large role in the patient's level of consciousness at the start of the procedure. The doctors give additional doses 5 to 55% of the time. Interestingly, the doctor with the second highest starting dose of 91.03 gave additional doses 55% of the time. The doctor with the second lowest starting dose only gave extra medicine 5% of the time. In conclusion, our studies seem to indicate that the initial dose of medication at the start of the endoscopic procedure seemed to vary significantly between physicians. Since the average starting level of consciousness is close statistically, it can be assumed that other factors may be playing a larger role in the patient's level of consciousness at the beginning of the procedure. Here are a few of my resources. I would like to take this time to thank the program facilitators Rosalind Strickland, Nedra Starling, the Office of Civic Education Initiatives, as well as my mentor, Dr. Richard Gutman, my co-mentor, Teresa Rowe, as well as Dr. Murphy, Dr. Siebel, Dr. Peabody, my peer mentor, Michael Ransky, and my co-student, Matthew Peterson, as well as all the nursing staff in the Worcester Endoscopy Unit. Thank you.